Many thanks for participation in this session, and many thanks to Professor Ermin to give this very nice introduction together with Professor Vanucchi. So in part one, we would like to learn more about diagnosis of advanced SM. And I'm very happy that Professor Sotlar from the Institute of Pathology at the Medical University in Salzburg is today with me in this session. So my name is Professor Andreas Reiter, and I am a hematologist at the University Hospital Mannheim in Germany. So I would like to start my part with the clinical presentation and diagnosis. So these are my disclosures. So this is the summary of the clinical presentation and of the diagnostic procedures, and in consequence, the subclassification of patients with advanced systemic mastocytosis. On the left side, you can see the patients really suffer from a lot of symptoms, and these are really very sick patients. So they have symptoms like anaphylaxis, flashing, fatigue, diarrhea, and weight loss, and they have particularly symptoms due to organ involvement and organ damage, like organomegaly, portal hypertension, and ascites. And in the peripheral blood, it's all very similar to, let me say, CLL or myeloma. If patients have severe mast cell infiltration of the bone marrow, they obviously also suffer from cytopenias like anemia and thrombocytopenia. And also, due to organ damage, we see hypoalbuminemia or elevated alkaline phosphatase because of infiltration of the liver. And we have a very, let me say, nice marker in the serum, which allows diagnosis, subclassification, and also monitoring of the disease, and that's the tryptase. And then we perform bone marrow biopsy. We do the tryptase, as just said, in the peripheral blood, and we perform a mutational testing. This is KIT D816V. And KIT D816V is present in more than 90% of the patients. So it's very similar to B-stable in CML, but check to V6NF in systemic mastocytosis. We then have the diagnosis. We check the C findings. You can see the C findings on the left side of the panel, like weight loss, splenomegaly, portal hypertension. And this allows us the subtyping of the disease in indolent or advanced systemic mastocytosis. And advanced systemic mastocytosis has three categories. This is aggressive systemic mastocytosis with associated hematologic neoplasm, and mast cell leukemia. And we will come to that in further detail during this presentation. And nowadays, also very important, and this is also a topic of this presentation, is next generation sequencing with the detection of somatic mutations and also cytogenetic analysis as very important prognostic markers. And this is just a summary of 20 patients. You see in the upper part of the panel the C findings of the patients, so the findings of organ infiltration and organ damage. And what you can see in these 20 patients, that most of the patients do not only have one C finding, but several C findings. And you may really agree with neutrophilia, anemia, thrombocytopenia, and low albumin due to liver infiltration. These are obviously really very sick patients. But in the lower part of this panel, you see additional symptoms and signs of organ damage, which are not included in the C findings. And this, for example, includes abdominal lymphadenopathy, GI infiltration, diarrhea, skin involvement, and many other laboratory parameters, which clearly indicate that this disease is really something like an advanced disease. And then after we have seen these presentations, we perform, as said, the bone marrow biopsy. And now I want to hand over to Professor Sotlar from Salzburg to give us a first introduction, what he actually checks in the bone marrow biopsy.
Thank you, Andreas. Good evening from my side too. These are my disclosures. The diagnosis of systemic mastocytosis is based on WHO-defined diagnostic criteria. SM, systemic mastocytosis, can be diagnosed when the major criterion and at least one minor criterion are fulfilled, or in the absence of the major criterion, at least 3 minor criteria are fulfilled. These criteria are the major one, the detection of multifocal compact infiltrates of at least 15 mast cells, and now that's important, in bone marrow sections and or other extracutaneous organs. So the skin doesn't count here. There are 4 minor diagnostic criteria. The first one, the detection of at least 25% of atypical, that means spindle-shaped mast cells. The second one, the detection of the KIT mutation D816V or other mutations in this exon. The third one, an aberrant expression of CD2 and or CD25 in mast cells. And lastly, persistently elevated serum tryptase level exceeding 20 nanograms per ml. In the upcoming WHO classification, there are minor additions to the minor diagnostic criteria. This is that also other KIT mutations do count as minor diagnostic criteria, and CD30, the aberrant expression of CD30, is added as a minor criterion. How do atypical mast cells look like? We have here bone marrow aspirate smears, and you see on the left normal round mast cells. Atypical mast cells usually are spindle-shaped and hypogranulated. More atypical mast cells even may contain 2 nuclei. And in the rare occasions of metachromatic blast cells, these are blastoid cells containing metachromatic blasts, which can be found in some cases of mast cell leukemia or myelomastocytic leukemia or tryptase-positive AML. The diagnostic hallmark of systemic mastocytosis is the detection of compact mast cell infiltrates. And one is shown here in the right picture in a Giemsa stain. You see all these spindle-shaped, they are markedly hypogranulated, and you can see that this is a mixed infiltrate, also containing lymphocytes and eosinophils. Please keep in mind that the metachromatic granules cannot be detected in an H&E stain. So at least you need to stain for Giemsa to count mast cells. Counting mast cells, of course, is much easier when using appropriate immunohistochemical stains. This is tryptase and CD117 for the detection of every reactive and neoplastic mast cells, and CD25 in neoplastic states. This in immunohistochemistry is the most sensitive marker. And you can see here in the upper right that there are 2 compact mast cell infiltrates, and in addition, there are a lot of loosely scattered mast cells. Most of them are spindle-shaped. In rare cases, these neoplastic mast cells also express CD30. Please be aware that mast cells express a lot of other antigens, as shown in the last sentence of this picture. These expression of additional markers may to differential diagnostic problems with other neoplasms. So now I would like to hand back to Andreas.
Yeah, so we now come to the next part of my presentation, and this is now the problematic diagnosis of advanced systemic mastocytosis. And the problem is that the disease is much more complex than previously thought for a long time, and we have just revealed in the last 5 to 10 years what is genetically really going on in this disease. So we have learned about KIT D816V being present in more than 90% of patients. But it's not only KIT D816V in mast cells. It's a lot about that we also find KIT D816V in other hematopoietic lineages, and in many patients, in almost all of them. So we find KIT D816V in monocytes, we find them in eosinophils, and sometimes even in lymphocytes or in cells of the megakaryocytic. Okay, and in the lower part of this, you see that in addition to KIT D816V, we find in up to 60 to 80% of the patients with advanced systemic mastocytosis additional somatic mutations. And these are the same which we already know from other myeloid neoplasms, like CMML or myelofibrosis, so mutations in SRSF2, AS6L1, or RUNX1. And if these mutations are present, we have the most advanced forms of systemic mastocytosis in combination with KIT D816V, something like mast cell leukemia with associated hematologic neoplasms. And these mutations are not only important for pathogenesis, but also for prognosis of the disease. And here you can see two prognostic scoring systems. In the upper part of this figure, a score without additional somatic mutations, and in the lower part, a score with inclusion of additional somatic mutations, and this is called the mutation-adjusted risk score. And in this analysis, we have actually performed the same what others have done for chronic myelomonocytic leukemia or myelofibrosis. So we have combined clinical parameters such as anemia and platelets, plus the additional mutations. And not even the presence of additional mutations, but also the number of additional mutations is important. You see then that according to all that, we have three risk groups: low, intermediate, and high-risk patients. And you see on the left side, the median survival of these patients. So for high-risk patients, 1.9 years, for intermediate risk patients, 3.9 years, and for low-risk patients, is it not yet reached. And I think you all can imagine that this type of survival curves obviously has a great impact on clinical decision-making. For example, how long to keep a patient on a tyrosine kinase inhibitor or another treatment, or if a patient is better to go ahead with allogeneic stem cell transplantation. So in summary, the problem of advanced systemic mastocytosis is really that we are missing advanced systemic mastocytosis, and we see too many patients with incorrect diagnosis. And this is particularly because of systemic mastocytosis with associated hematologic neoplasm. So the problem is that there are too many patients in which we miss in a diagnosis of CMML or chronic eosinophilic leukemia, the systemic mastocytosis. And here you can see that in our series of overall 140 patients, we actually identified the patient with advanced systemic mastocytosis in a group of 28 patients, making 20% of the overall cohort. And we identify advanced systemic mastocytosis, and particularly AHN, by routine screening in peripheral blood of the serum tryptase, by routine screening in patients with elevated tryptase for KIT D816V, and also with asking pathologists to have a second look into the bone marrow biopsy when we have positive results. But on the other side, we also see patients who are diagnosed with indolent systemic mastocytosis because of a relatively low number of infiltrating mast cells. And in these patients, it is also very tricky and dangerous to oversee the AHN, so to oversee the multilineage involvement of the disease. And here again, you can see that we identified 23 patients based on that. And again here, so you can easily identify patients with supposed indolent systemic mastocytosis, the advanced disease, for example, by performing KIT D816V allele burden testing in peripheral blood, because this is usually then created by other myeloid lineages. So in this series, the median allele burden was 28%, or when you find monocytosis or eosinophilia, and even if you do progressed analysis, also including genetic analysis, you may also find the additional somatic mutations in SAR, as we also did here. So we found that in about 50% of patients. So now with this new knowledge on the complexity of advanced systemic mastocytosis, particularly AHN, particularly the multilineage involvement of KIT D816V, and also the presence of additional somatic mutations, I now want to give back, the talk to Professor Sotlar, and also now really to highlight what he can provide from his perspective to really identify the patients better.
Thank you, Professor Reiter. Yeah, the diagnosis of systemic mastocytosis is usually no big problem if the cases look like shown here. ISM with 2 compact infiltrates, aggressive systemic mastocytosis with a marked fibrosis, SMAHN with a compact infiltrate in the upper left and the myeloid neoplasm in the lower right, or mast cell leukemia with these highly atypical mast cells with these vacuolated cytoplasm. I would like to show you now 3 scenarios demonstrating what Professor Reiter has described before. I think we can differentiate between scenario 1, when SM may be missed in cases of a predominant AHN. This may be a AML, or when compact mast cell infiltrates are missing. Please keep in mind that there are no compact mast cell infiltrates in about 25% of cases. Scenario 2 is when AHN may be missed in cases with a predominant SM component, which is the case in ASM and mast cell leukemia. And scenario 3 is when both disease components are high grade and one may be obscured by the other one. So the first case is a patient with acute myeloid leukemia. When you here stain for tryptase, you see no compact mast cell infiltrates. In fact, you only see one mast cell, but this mast cell is spindle-shaped. After cytoreductive therapy, we see regenerating hematopoiesis and an increase in almost all spindle-shaped mast cells using tryptase. These cells also expressed CD25, and the KIT D816V mutation was also detectable in this patient. So in fact, this patient has SM-AML, so SMAHN, with an SM component being obscured at first presentation. Second scenario, you see a bone marrow biopsy specimen with a marked fibrosis and also an osteosclerosis. Using tryptase, you see that there are a lot of mast cells within these reticulin fibers. And it's the problem here to find minor areas with remaining hematopoiesis, which looks quite atypical here, together with the clinical information that there's also monocytosis. We were able to make a diagnosis of ASM CMML in this patient. This patient also had the KIT mutation D816V. And the third scenario is 2 high-grade neoplasms. We see a lot of blastoid cells here, 2 atypical megakaryocytes. And by using a GIMSA stain, we can see that a lot of these blastoid cells contain a lot of metachromatic granules. These are mast cells, as can be demonstrated by the tryptase immunostain. But there are a lot of cells that do not stain for tryptase. These cells express MPO, which mast cells never do. So here we have a combination of aleukemic mast cell leukemia and acute myeloid leukemia. So taken together, please be aware that at least 25% of SM cases don't present with compact mast cell infiltrates. And please take home this message that we highly recommend to use a panel of immunohistochemical markers to detect mast cells. This is tryptase, CD117, and CD25. And a panel of markers when an AHN, a myeloid neoplasm, is in question. This is CD34, CD42, or CD61 for megakaryocytes, CD71 for erythropoietic cells, CD14 for histiocytic cells, and maybe you may add additional markers. So this is an important take-home message from the pathology. And with that, I would hand back to Professor Reiter.
So what is really important from the first part of this section is that you have learned the diagnostic criteria of systemic mastocytosis in the clinical settings, but also from the pathologist's view. And then it is absolutely most important that we should not miss patients with systemic mastocytosis at all, and particularly the patients with advanced systemic mastocytosis, because, as you will see in the second part of this presentation, we really have very effective targeted treatment for these patients. So what you should do is that in every patient with a suspicious presentation, like anaphylaxis or like monocytosis or eosinophilia, particularly the combination of monocytosis and eosinophilia or elevated alkaline phosphatase, perform a serum tryptase. It is about 20 to 30 euro per individual patient, and obviously much cheaper than genetic testing. But if the tryptase is elevated, you should definitely also perform a KIT D816V mutation analysis. Nowadays, with sensitive assays, you can do that in peripheral blood. It would be best to do that in a quantitative form, so quantitative assessment of the variant allele frequency of KIT D816V in peripheral blood. And then, even if in the absence of a valid bone marrow biopsy, by the combination of both, you can not only diagnose, but also already subtype the disease with the combination tryptase low, KIT low. On one side, that this is most likely ASM, and on the other side, for example, tryptase high and KIT D816V high, meaning this is most likely advanced systemic mastocytosis. And then you can either perform the bone marrow biopsy, or you go back to your pathologist, tell him about your findings, and that he should double check his biopsy whether there's anything missing, either systemic mastocytosis or the associated hematologic, usually in almost all cases, myeloid neoplasm.